Hello students, today we are going to be talking about nerve blocks, specifically about the inferior alveolar nerve block. Before we understand how to give an inferior alveolar nerve block, we need to understand the anatomy and the distribution of this nerve. Coming to the anatomy of the inferior alveolar nerve, we know that the trigeminal nerve has got three branches, of which the third branch is the mandibular division. From the posterior aspect of the mandibular division, we have the inferior alveolar nerve as well as the lingual nerve, which runs in close proximity to the inferior alveolar nerve. The inferior alveolar nerve supplies all the teeth from the molar up to the central incisor. It also supplies the soft tissue, which is the labial gingiva, in relation to the premolars up to the central incisor. It also supplies the lower lip and the chin on that side. To extract any tooth in the mandible, we need to anesthetize not only the hard tissue, but also the soft tissue on both the labial as well as on the lingual side. The entire lingual soft tissue is supplied by the lingual nerve, and this nerve is also blocked along with the inferior alveolar nerve separately in the same needle insertion to extract any teeth in the mandibular quadrant. Since the terminal branches of the inferior alveolar nerve are the mental nerve and the incisive nerve, these two branches are automatically anesthetized along with an inferior alveolar nerve block. To extract a mandibular molar or the second premolar, we additionally need to give a long buccal nerve block which supplies the soft tissue of the buccal gingiva in relation to these teeth. Further, regarding the anatomy of the inferior alveolar nerve, the lingual nerve and the inferior alveolar nerve come as a common trunk. Just before the mandibular foramen, the lingual nerve is separated out. It lies anteriorly and medially to the inferior alveolar nerve and supplies the lingual soft tissue and the floor of the mouth as well as the lateral aspect of the anterior two-thirds of the tongue. The inferior alveolar nerve enters the mandibular foramen. It runs through the body of the mandible in a canal up to the mental foramen region. In the region of the mental foramen, the mental nerve separates out and comes out into the soft tissues, whereas the incisive nerve continues inside the mandible and supplies through a plexus all the teeth in the anterior region. So when we give an inferior alveolar nerve block, the terminal branches, which are the mental nerve as well as the incisive nerve, are also blocked along with it. Coming to how to give the inferior alveolar nerve block, the doctor should be standing at a position around 7 o'clock in the right front position of the patient. The patient is kept in an upright position with the backrest at 90-degree angulation to the floor. We need to first understand the anatomical landmarks to give any nerve block so that we are accurately able to locate the nerve before we inject into the tissues. For the inferior alveolar nerve block, we need to identify certain hard and soft tissue landmarks. What are the hard tissue landmarks that we need to identify? One would be the anterior border of the ramus, the external oblique ridge. This is a ridge that continues downwards from the anterior border of the ramus, the internal oblique ridge, the premolar teeth on the opposite side. And we know that the mental nerve lies just below the premolars, in between the two premolars. The soft tissue landmarks that we need to identify are the pterygomandibular raphe. When the patient opens their mouth wide, there is a small band of tissue that you see extending from the maxillary tuberosity all the way to the retromolar trigone. This is called the pterygomandibular raphe. There's a buccal pad of fat which is present within the cheek here. You also have to identify the retromolar triangle, which is the soft tissue pad that is present just distal to the third molar in that region. The other landmarks that we also need to identify are the posterior surface of the ramus of the mandible with the finger inside the mouth on the coronoid notch. The other two fingers are placed on the posterior surface of the ramus of the mandible. This will help us in not only identifying the width of the ramus of the mandible, but also gives us an idea of how flaring the mandibular ramus might be. This would be to identify the coronoid notch, and another important landmark is the opposite side premolar. So during our inferior alveolar nerve block, our target area would be to reach the medial surface of the ramus of the mandible as close to the mandibular foramen as possible. So let us now identify the various landmarks that are required for giving an inferior alveolar nerve block. That is the anterior border of the ramus, which continues downwards as the external oblique ridge. That is the internal oblique ridge. That is our target area, which is the mandibular foramen region on the medial surface of the ramus of the mandible. That is where our needle will be finally reaching. That is the posterior surface of the ramus of the mandible. We need to identify the coronoid notch. To identify the coronoid notch, we place our thumb on the anterior border of the ramus and pass it up and down the external oblique ridge and the anterior border of the ramus till we come to the deepest part of the anterior border, which is called the coronoid notch. With the finger in the coronoid notch, we place the remaining two fingers on the posterior surface of the ramus. This gives us an estimation of the width. Also, with the fingers in this position, the mandibular foramen lies exactly in line with the thumb that is placed on the coronoid notch. Also, the mandibular foramen lies in between the two fingers that are placed, one on the coronoid notch and one on the posterior surface of the ramus of the mandible. The finger is then placed on the internal oblique ridge, and along with all the soft tissues, it is retracted outwards, keeping the finger still on the coronoid notch. With our finger in this position, we will reach the target area, which is the mandibular foramen on the medial surface of the ramus. Now, taking our needle from the opposite side premolar, we bisect the fingernail that is present on the coronoid notch and go exactly till we reach bony resistance on the medial surface of the ramus of the mandible. This is as close to the mandibular foramen as possible. If we approach the mandibular foramen from the anterior region, we do not feel any bony resistance. And if we approach it from the molar region, we see that we contact the bone too early on the internal oblique ridge, which is also not accurate. So going from the opposite side premolar is the only way to reach the mandibular foramen. Intraorally, if we were to examine the coronoid notch, we should ask the patient to open their mouth wide, identify the pterygomandibular raphe, which is the soft tissue structure that is present here. We retract the entire tissue buccally to visualize a pterygomandibular depression. So this is how it is done. We first ask the patient to open their mouth wide. We feel for the anterior border of the ramus and the external oblique ridge, and then place our finger on the coronoid notch, retract all the tissues from the internal oblique ridge outwards, and identify the pterygomandibular depression with the patient's mouth wide open. So to reiterate our final position of the needle, keep the thumb on the coronoid notch, the other two fingers holding the posterior border of the ramus of the mandible, identify the pterygomandibular raphe, visualize the pterygomandibular depression, and the needle is inserted from the opposite side premolar. Make sure you feel the bony resistance, and in this position, the needle will now be close to the mandibular foramen. You are now ready to inject for the inferior alveolar nerve block. So to again go ahead with understanding what is the incorrect and correct position of the needle, like I told you earlier, the correct position would be when you come from the premolar region only. If you come more anteriorly, you will not feel bony resistance, and if you go too posteriorly, you will feel the internal oblique ridge, which is encountered too early, with the needle not going all the way inside. So how do you find out if your nerve block is working? There are something called subjective and objective symptoms. In the subjective symptoms, the patient will tell you that they have tingling and numbness of the lower lip and chin, and numbness is also experienced on the lateral border of the tongue on the same side if the lingual nerve block is also given. Now, to give a lingual nerve block along with an inferior alveolar nerve block, we need to just withdraw the needle about a centimeter, in which case the needle is lying anteriorly and medially to the inferior alveolar nerve, and this is exactly where our lingual nerve is present, and you can anesthetize lingual nerve in that position. The objective symptoms for checking an inferior alveolar nerve would be to probe with a blunt instrument in the region of the premolar to see whether the patient is experiencing any pain. So what are the possible complications you can get with an inferior alveolar nerve block? One would be failure to achieve anesthesia. In case we do not identify all the landmarks properly, there is a possibility that you may not be able to block the nerve well. The inferior alveolar nerve travels along with a vascular bundle, which is the vein as well as the artery. Damage to this vascular bundle can cause hematoma and bleeding into the soft tissues. Trismus is another complication with an inferior alveolar nerve block. Now, why do we get trismus with an inferior alveolar nerve block? This is because the medial boundary of this pterygomandibular space, that is the place where we inject for giving the block, is bounded by the medial pterygoid muscle. If we were to puncture this muscle multiple times with our needle, there's a possibility that this muscle might go into spasm, because of which the patient might experience trismus. Transient facial nerve paralysis is another possible complication that can happen. This is because the parotid gland forms the posterior boundary of the pterygomandibular space, and being the posterior boundary, if we do not encounter bony resistance and our needle goes too much posterior beyond the ramus of the mandible, in this area we might be injecting directly into the parotid gland, and because the facial nerve lies within the substance of the parotid gland, there is a chance that there is a paralysis of the facial nerve. And as we call it a transient facial nerve paralysis, it lasts as long as the effect of the nerve block remains. So during this time, the patient might have a transient facial nerve paralysis. So this was to do with the inferior alveolar nerve block. We discussed the anatomy and distribution of the nerve. We talked about the various hard tissue and soft tissue landmarks, the doctor and the patient position. Also, we talked about the technique of how to give the inferior alveolar nerve block. I hope this was useful to you. Thank you very much.